Thank you everyone for attending the Department of Global Health and Population Brown Bag Series. My name is Fong Pham, a faculty member in the department, and I'll be the moderator today. We're delighted to have Dr. Sylvia Kehlenbrink, who will lead us through the discussions on diabetes cares in humanitarian settings. By way of introductions, Dr. Kehlenbrink is an endocrinologist and a director of global endocrinology at the Brigham and Women's Hospital, and is a part-time instructor at the Harvard Medical School and the founder and the director of Diabetes in Humanitarian Crisis Program at the Harvard Humanitarian Initiative. She graduated from medical school at the Charity University in Berlin, completed her residency in New York and her fellowships here at the Brigham and Women's Hospital in Boston. Her research focus has been on diabetes cares in humanitarian setting and improving insulin access in low and middle income settings. In her current position, she leads the humanitarian NCD interagency studies in emergencies and disaster study and consists of 6 leading international humanitarian organizations and has the goal of improving diabetes care in humanitarian context through collaborative practice-based research. She is now leading the newly formed International Alliance for Diabetes Actions, which seeks to address the targets in Boston Declarations. So before I hand over the microphone to Dr. Kehlenbrink, I want to remind everyone that the speaker's remarks are based on their own scholarships and experience, and as such, they speak for themselves and not for Harvard. Welcome, Sylvia.
Thank you. Thank you all for coming. Very nice to meet you all. It's a privilege to be here. And yeah, I'll be talking about diabetes care in humanitarian settings. Just the disclosures. I'm going to spend the first part of the talk on giving some background and then discuss some of the current challenges around providing diabetes care in humanitarian settings. And then at the end, discuss current initiatives, impact initiatives that have recently started. If anyone has a question, just please feel free to interrupt at any point in time. So I'm sure this audience is well aware of the statistics, but by way of background, there are over 500 million people globally right now with diabetes, of which about half are undiagnosed. The vast majority live in lower and middle income countries, and rates of early onset diabetes, so diagnosis younger than age 40, are increasing pretty significantly. And you'll see here on this map that the parts of the world where we're expecting the largest increases in diabetes prevalence over the coming decades are in Africa, 134% increase, the Middle East and North Africa and Southeast Asia. So those are the parts of the world that are projected to be the hardest hit. And most recent estimates predict that there could be more than 1.3 billion people with diabetes by year 2050. At the same time, the numbers of people forcibly displaced globally are at record high numbers. There too, the vast majority live in lower and middle income countries, and over 60% are in protracted settings, meaning the crisis goes on for years, on average decades. Some people are displaced for most of their lives, or born into refugee camps or in displaced situations, and so humanitarian providers are having to provide long-term chronic disease care. And you'll see here, this graph shows you the proportion of forcibly displaced people. The green are internally displaced, meaning they've been forced to flee from their homes, but they're still within their country of origin. And then the blue right here, those are refugees that have to flee and cross an international border. So the vast majority are IDPs, the internally displaced individuals. And this is a map showing you the parts of the world that are hardest hit by humanitarian crises. The orange is due to natural disasters, the blue due to conflict and violence. There are about 200 million people that are affected by natural disasters each year. And the most recent projections are that 1.2 billion people could be displaced by 2050 due to climate change and natural disasters. So this is huge, these are huge numbers. And if you look at these two maps, you'll see that those parts of the world where you have the most natural disasters, conflict affected displacement and diabetes, they overlap pretty much almost identically. And so, you know, equipping humanitarian providers and countries to manage NCDs and diabetes is critically important. That said, so the acute emergency phase, depending on definition, some people say it's the first 3 months, others the first 6 months, but in the acute phase, urgent and targeted assistance is of course needed. You have to identify those that are at highest risk of immediate mortality and morbidity. And that's often done based on an existing epidemiological data and on a joint needs assessment. So humanitarian providers, when they respond to an acute crisis, one of the more common ways of estimating needs is through this MIRA, the multi-sector initial rapid assessment, that they all collect this data to say, okay, what are the main challenges, the main kind of diseases we need to address that will help with funding calls, et cetera, et cetera. And then based on that data, they will then deploy a minimum initial service package. So services, like just minimum services to get people through that initial phase. However, baseline diabetes data are often lacking in lower and middle income countries at baseline. Diabetes, as I mentioned earlier, is often undiagnosed. 50% of the people are walking around not knowing they have diabetes. And there are no uniform or standardized indicators for data collection. They're not part of the MIRA, so the MIRA doesn't necessarily collect NCD-related data. Even across organizations, data is not collected consistently. This is a bit of an older graph, but it still holds true today from UNHCR, their NCD consultations across their sites. And you'll see that the proportion is like minuscule, and it's not because it's not there, it's because they're not measuring it. And there are no predefined minimum standards. Even insulin, which is an essential drug and a life-saving medication, obviously for someone with type 1 diabetes, is not routinely included in a humanitarian response. That's a death sentence for some people. And so there was no really, no published literature on this. And so what we did a few years ago was convene the United Research Consortium, which consists of these 7 humanitarian organizations here, to say, okay, what data are they collecting that's not been published, but what are they collecting? And understand, you know, their organizational practices around diabetes care delivery, data collection, and what are the key challenges that they're facing, with the plan then to go on to a phase 2 where we develop standardized indicators, like a bare minimum set of indicators that they would all collect in the fields in order to help with this issue. And so these 4 organizations, the International Committee of the Red Cross, the International Rescue Committee, Doctors Without Borders, and UNHCR, contributed to the data collection or this particular study. And what we did was a cross-sectional survey of diabetes care delivery across all of their medical services in the year 2018. And so we randomly selected 83 sites stratified by global region across these organizations. And of the 83 sites, 65 or 78% reported collecting some sort of data on diabetes. The sites that were included were across 27 countries and 5 global regions. You'll see them here in blue. Most of the sites were in the Eastern Mediterranean region and in Africa. Most of the sites were either refugee camps or rural non-camp sites. The populations that the humanitarian providers were serving in those settings were mostly a mix of refugees, IDPs, and the general population. I think that's important to note that humanitarian providers also care for the local population. So they're providing broad care for a variety of people. And most of the sites were in protracted conflict situations. So very few acute and very few due to natural disasters. Looking at the type of data that these organizations were collecting, it really just kind of confirmed what we had already known, like anecdotally. There's no standardized data collection system. So for example, an organization might be collecting data on diabetes via Excel spreadsheet in Sudan. In Chechnya, they're collecting data via an electronic medical record, but not on diabetes. So even within an organization, so there's no way of comparing or really being able to analyze this data properly. And then of course, across organizations completely. I mean, every organization doing something else. Less than half of the sites reported who's on insulin, which is probably the most important initial data point, like, okay, who needs insulin? Not collecting that kind of data, and very few collecting any data on complications. I mean, you know, minuscule numbers there. And then 1/3 of the sites did not provide any insulin at all. And what I thought was really striking was that only 14% of the internally displaced persons camps provided insulin, and those are the majority of people who are displaced or IDPs. And so, you know, this is not a medication that humanitarian providers are routinely providing. Now, I should say that insulin availability is a huge challenge in lower middle income countries at baseline. So it's often unavailable in the public sector. If it's available, it's in the private sector, generally speaking, and it's very expensive in humanitarian settings. Up until recently, I will say, insulin has been reserved for inpatient care only. So you go to the hospital, they'll give you insulin, they'll treat your diabetic ketoacidosis or whatever it is, but they will not send you home with it. So these individuals, it was just a revolving door where they'd go home, you know, they don't have insulin. It just, yeah, very frustrating. And then when it is available for ambulatory care, it's often only dispensed at the hospital level, which is often very far away from where people live. So they have to travel far distances, and obviously humanitarian contexts are not safe. And so with people, you'd hear Doctors Without Borders talking about their camps or their hospital sites, and people with type 1 diabetes would move and have their tents right next to the hospital because the kids would have to go to the hospital multiple times a day for insulin injections because they wouldn't give it for home use. One of the reasons why that is the case and they won't provide it for home use is insulin storage. So insulin needs to be refrigerated, ideally speaking. But as you'll see here, a lot of parts of the world where these humanitarian crises occur do not have refrigeration, and it's hot, oftentimes hot. And so, you know, where are you going to store the insulin? So oftentimes they'll use these little clay pots where you have water down here in this little bigger pot to keep it cool, and then in the middle one you'll put the insulin, and that actually does do a pretty good job of keeping it cool. But this has been a huge barrier to access. Now, for an acute emergency response, there is such a thing called the Interagency Emergency Health Kit, which the WHO and UN agencies can deploy when needed in an acute crisis. And these kits provide basic medical services for a population of 10,000 people for 3 months. So you can order however many of these you want based on the population affected. And up until, I want to say around 2016-ish, give or take a year, there was no insulin in any of these kits either. But they did develop a non-communicable diseases kit that you can buy separately with a cold chain. And that does contain some oral hypoglycemic agents, glibenclamide, metformin, and then various human insulins. These are somewhat older insulins we don't use as much in the US, but they're very effective, and they are included in those kits. The problem is that there are no instructions on how to use these insulins, and people may not be on these insulins, and these are often not deployed on time. So you'll hear stories of someone ordering them and they show up a year late. They're working on it, it's getting better, but it's still a challenge. Insulin affordability. I won't spend a lot of time on this, but I think we all know insulin is very expensive even in this country. Prices vary among countries, health sectors, and are often not publicly known. So Doctors Without Borders will pay one price, the International Red Cross another price. They can't tell each other what they're paying. It's not supposed to be disclosed. A 10 milliliter vial of human insulin in MSF projects can range anywhere from $2 to $12. And the newer analog insulins that a lot of people are now on are much, much higher priced than the human insulins. And for example, here in the US, we typically use insulin pens. Those are very expensive, especially in LMICs. And so they're still using a vial and a syringe. And now can you imagine you have visual impairment or any dexterity issue, or you're running, or you're using small doses of insulin, using a vial and a syringe like that, very challenging. And then on top of this, diagnostics. This is something that people have not talked about much up until recently. This has kind of gone unnoticed, but you have to be able to measure your blood sugar if you're using insulin. Otherwise, you're driving a car kind of blindly. And here you'll see the costs. So the blue, these different countries here, This is the percent cost to a patient with diabetes in terms of their supplies. Blue is insulin. The red are the meters and strips. So the highest percent of cost are the diagnostics. And they're often not available at all in these settings. Very, very tricky. In the United study, when we looked at this, home glucose monitoring and A1C, which is a way we test average blood sugars, are rarely available. Even capillary glucose, which is a finger prick, the most standard way of checking the glucose, was available in only 71% of sites. About 30% wouldn't even be able to check a glucose level. 19% of sites had A1Cs available, home glucose monitoring, 22%. So not really routinely available. And then clinical management. As we know, lower middle income countries often have insufficient numbers of healthcare workers at baseline. That, of course, is exacerbated in a crisis. People leave. And in many LMICs, diabetes is considered a specialty issue. So only specialists will manage it, not primary care. So many of the healthcare workers that are working at primary care level don't know how to manage. So there's a lack of knowledge there. And there are no clinical guidelines. Doctors Without Borders created a guideline of their own, but a lot of organizations will use the WHO PEN guidelines, which are good, but they're not necessarily adapted to these settings. They need some adjustment, and they haven't been looked at or validated. So that's been another challenge, and different organizations are using different guidelines. I'll touch on this only very briefly, just to say that diabetes looks differently in different settings, and providers are picking up on this and unsure as to how to manage this. So for example, this was in the Democratic Republic of Congo, Doctors Without Borders, or MSF, one of their diabetes clinics. They looked at 243 patients that were enrolled within their diabetes clinic. Average age was 45, but the mean BMI of that cohort was 21. That's a low BMI. 31% were underweight. This is a huge statistic for most people in the world have type 2 diabetes. And when they looked at based clinically, only just clinically, again, because they can't check antibodies or C-peptides and things like that. When they looked at the phenotypes, they categorized 26% as having classic type 1, what they thought like probably had DKA or something like that, which is a very high percent. Globally, we think maybe 5% of the diabetes population have type 1. So this is a large percent. About half had type 2. And then 23% an indeterminate form of diabetes, unclear what, didn't fit any classic categorization. So their hypothesis in this paper was, could it be malnutrition-related diabetes? Now, briefly, malnutrition-related diabetes, this was an entity of diabetes that was originally recognized by the WHO in 1985 as a distinct form of diabetes that was related to undernutrition, malnutrition when you were in utero, if the mom was undernourished, or in your very young years of life. But in 1999, they revoked this, saying, nope, there's not enough data to support this. So this is actually no longer an official WHO phenotype. But there's a lot of discussion around this. The common features of this are, like I said, malnutrition in childhood and utero with persistently low BMI. Generally early onset diabetes under the age of 30. The hallmark here is that despite very high blood sugars, they never go into diabetic ketoacidosis, which would be typical for type 1 diabetes. So this is kind of the hallmark. They look very thin. These are some old pictures from India, I believe. And so anyway, but they develop, unfortunately, all of the diabetes complications. I did some research during my residency with a group in India looking at this low BMI form of diabetes. And we compared it to a leaner type 2. In India, the BMIs tend to be a bit lower when they develop diabetes and other NCDs. So looking at regular type 2, type 1, people without diabetes, and then this lean diabetes, BMI less than 18.5, never been in DKA. And we did these clamp studies, these complicated studies looking at insulin sensitivity and secretion. And you'll see here, the light blue is their insulin secretion. So this line here, I guess, whatever you want to call this, peach colored, is type 1. They make no insulin whatsoever. The black here is type 2. They make some insulin, but not as much as a normal healthy individual. And these lean, questionable malnutrition-related diabetes, they just make less insulin, and the idea is, could the beta cell not have developed properly in the setting of undernutrition in utero? So my point being that there's these different phenotypes of diabetes that we don't see here or in high income countries necessarily, that these providers are encountering and they don't know how to manage. I mean, none of us really do, quite frankly. They're usually managed with insulin. And then, of course, you have to adapt the service design in humanitarian settings, looking at the existing health system. You know, the Ukraine is not the same as Sudan. What's available? What are the resources available? What are the population characteristics? Most displaced populations live in cities, no longer in camps. And displaced populations are not routinely included in national health systems, so they're kind of managed outside of those systems. And of course, there are a lot of mental health disorders and psychosocial challenges, as you know, goes without saying in these situations. Insecurity, I won't belabor this, but you know, we know there are chronic levels of conflict and instability in these settings, and increasingly, unfortunately, there are direct attacks on humanitarian healthcare workers. And so the model has to evolve. You know, if you're in Ukraine, for example, and it's stable for a minute, you can provide services, all of a sudden it erupts again and bombs start flying. You kind of have to scale back and forth. So, you know, your model of care is ever changing. And then lastly, NCDs are arguably the most underfunded thing in health, global health in general. And that is especially true in humanitarian settings. This graph shows you the percent global funding or development assistance, I should say, for health. And this is 1990 to 2018. And you'll see down here, this is infectious diseases, newborn child health. Up here, this little sliver of orange is all NCDs combined. And you'll see there's been zero change over this whole time frame, not one change. All the while, the prevalence, we all know, is increasing incredibly. So huge challenge. You know, if it's not funded, guess it's not going to happen. So it's depressing. It's very overwhelming. And I think here we have all these different sectors that need to come together in order to address. There's no single entity in the world that can solve this issue. You have all these different groups that need to work together. And in 2019, we convened our first meeting on diabetes and humanitarian crises here at Harvard, bringing together, at the time it was over 100 individuals from various sectors, various backgrounds that were interested in this or working on this, just to say, okay, is this an issue? Yes or no? Let's hear from people working in the field. What are the main and most urgent things we need to work on? Because this is work of a lifetime. This is not going to be solved tomorrow, but what do we need to fix first and prioritize? And so this group essentially did that, and we published the so-called Boston Declaration, basically outlining to say, you know, adults and kids with type 1 diabetes who cannot access insulin are at acute risk of death. This is probably the most immediately fatal NCD out there. It's a human rights issue. And also that an effective diabetes platform provides, you could argue that if you can treat diabetes well, you could probably treat most other NCDs well. That shares a lot of comorbidities with cardiovascular disease, you know. So if you can do diabetes well, and then integrating other NCDs into it. So we're not saying just focus on diabetes, nothing else, but in any case. And then the group set out 4 targets that we wanted to work on together: unified and strengthened advocacy, universal access to essential medicines and diagnostics, a unified set of clinical and operational guidelines, and improved data and surveillance. Those were kind of the big buckets. And so out of that came the International Alliance for Diabetes Action in order to accomplish those goals. I remember at the end of the conference, someone raised their hand and was like, okay, now we have all these like targets, but how can we make sure this doesn't just stay a stale declaration in some journal that nobody thinks about? And basically said, could you help us coordinate and launch this kind of collective impact initiative? And so that's what we ended up doing. The mission of this alliance is to improve access to high quality diabetes care for people in humanitarian crises. And it's essentially, I'll show you in a minute, but it's an alliance of over 130 organizations from all kinds of different sectors working together to address this complicated issue. And we have 5 working streams. One kind of that surrounds it all, leadership and collaboration, promoting collaboration, one on service delivery, medicines, diagnostics, data research, finance, and policy. So along the lines of the Boston Declaration. These are the various organizations that have been involved from, different backgrounds, different sectors. And this is our group. Each of the working streams has two different co-leads from different organizations that are helping. They all have other jobs, but part of their time is helping coordinate this work. And I'll just give you an idea as to some of the projects we've been working on over the past few years. I'll start with the pillars on the right. Those are the more active ones. Under service delivery, I co-lead this particular pillar with Philippa Boole. She's the NCD advisor of Doctors Without Borders in Geneva. And some of the work we've been doing, again, collaboratively, the WHO is working on guidelines for type 1 diabetes, pediatric and adult, and other forms of diabetes, gestational type 2, with a section for adapted to humanitarian settings. So very, very low resource settings. We worked on insulin switching guides. So like I said, these kids and a lot of providers if they carry insulin, it's the old human insulin, which a lot of people don't use anymore. Ukraine, for example, had, I think, 32 insulins on their formulary, 32 different kinds of insulin. And so now you have providers going in with like 70-30 pre-mixed insulin. Nobody knows how to use this. So how do you switch? So this was a request we got, how do you switch? So we created those guidelines, and now they're translated into like 5 or 6 different languages. An open access educational platform was created by Nuha and Yuri. They're here at Harvard as well. And then we have a nutrition working group, which needs a lot of help. If any of you here are nutrition, we love your help. This is not an easy one, and I don't have time to go into it, but we have a variety of organizations looking at, the double burden of malnutrition, and the food packages that are provided are like salt, sugar, oil, and some starchy thing, which is suboptimal for people with diabetes. So what we're doing is compiling a compendium of adapted guidelines, right? If you Google diabetes guidelines, you get 1 million hits. So if you're sitting somewhere in Sudan and trying to figure out how do I manage, it's overwhelming. So we're trying to put together a compendium. We have a clinical expert group that are adapting guidelines, not reinventing the wheel, but having medical societies that have created guidelines, just tweak them with the help of field providers that can say, this is what we need. How do we manage if you only have 1 strip a month? What do you do? And so they can help with these materials. That's our little switching guide. Operational guidance, how do you operationalize NCD care in a humanitarian response? UNHCR, ICRC, IFRC, and others have started looking at this and creating operational guidelines, and we're working with the World Health Organization on an operational manual that's currently like under final review. And we're hoping to develop a minimum initial service package for NCDs. Like, what should you have at minimum in your pocket if you're going into a crisis, So we're hoping to develop that. Access to medicines and diagnostics. The Foundation for Innovative New Diagnostics, they're a nonprofit based in Geneva that works with the World Health Organization. They're working with manufacturers to improve affordability of home glucose monitoring, A1C testing. They're even looking at continuous glucose monitors. Clinton Health Access Initiative is working on bundling of commodities. So if you get insulin, I think this could be helpful here in Boston as well, quite frankly, because if you order insulin, you separately have to order the pen needles, you separately have to order the strips, and the glucometer and the lancets. That's like fun. And it's complicated. So CHAI is working on bundling these commodities. If you have someone with insulin, how many strips do they need? How many syringes? And providing it as a bundle. And at what point do you bundle it? At what level in the supply chain? And then there's been a lot of work around insulin thermostability, which I'll tell you a little bit more about. Again, because this has been such a barrier to providing insulin. So MSF did at Dagahali refugee camp in Kenya. They did a study looking at different kinds of, so this is one of the sites where the kids literally had to go to the clinic multiple times a day for their injections. They were not giving these kids insulin to go home, or any adult for that matter. And they had these insulins, they kept them out in someone's home or, where they were living on the counter, not refrigerated. And they replicated this at a lab in Geneva, at the University Hospitals of Geneva, looking at fluctuating temperatures. So normally in Kenya, the temperatures fluctuate between 77 and 99 degrees Fahrenheit between day and night. And they found that over those 4 weeks, the insulin retained its structural integrity and its activity. And this was for them a game changer because now they felt comfortable giving these individuals insulin to take home for at least a month. And just don't keep it in the sun, put it somewhere under something in the shade, but you can use it. And that gives you a little bit more liberty and freedom to live your life to some extent than before. This was another real world setting insulin study done by Life for Child and some others in India, in one of the hottest cities in India during the summer, so very hot climate in Nagpur, India. And the open box temperature, again, they had it in people's homes, was between 85 and 90 degrees Fahrenheit. And they looked up to 4 months, like how long? And again, they replicated this in a lab. So, and after 2 months, virtually all of the insulin was still active and, seemed fine to use. And after 4 months, 37 of the 40 samples retained over 95% activity. So basically what this means, and then they looked at clay pots, and clay pots did a really nice job of keeping it cool enough. And so what this tells us is, ideally you should store your insulin in the fridge, sure. But if you don't have a refrigerator, don't throw it away, use it. It's probably fine. Freezing it is worse things. So anyway, this has been really helpful. And even the European Medicines Agency, they looked at this data and provided a positive scientific opinion saying, for these insulins, if you can't refrigerate it, you can keep it, you can use it outside of the fridge for a month, or store it. Because once you open it, you can use it for a month, but store it for a month. So then you have 2 months worth of insulin at home. And now hopefully they'll look at other kinds of insulins that haven't been studied yet, and this can be expanded. This is the diagnostics work I just talked about, and then data and research. So one of the things, as I mentioned earlier, the United 2 study, developing these, just a very small set of indicators that these organizations can collect at baseline that are similar across organizations, so that we can start to look at this and see progress made, or what are the needs, et cetera. So we're working on that with 10 different organizations. The Human 1 trial, briefly, just to say, this is a study that, again, in the United States, we use mostly newer analog insulins. Human insulins are mostly used everywhere else in the world. It's kind of a 2-tiered system, which is very bothersome to many of us. And the rationale, the WHO for a long time was reluctant to recommend analog insulin, because it's very expensive compared to the clinical efficacy. They felt that the clinical effects weren't that much better with the newer insulins to justify the cost for a healthcare system and a Ministry of Health that's like having to prepare their budget. But if you talk to anyone with type 1 diabetes, living with type 1 especially, they will, and they've tried both of these insulins, they're very passionate about how they feel with these different insulins. So we're doing this switching study in Tanzania and Bangladesh, looking at kids between ages 7 and 24, using blinded little glucose meters, just to understand which, if these insulins are in fact better, we're going to push a lot harder advocacy-wise to get these insulins lower cost. And then finally, financing and policy working stream. About a year or so after we launched this initiative, the WHO launched the Global Diabetes Compact, which is essentially coordinating on a macro level all things diabetes, and trying to look at a variety of all of these issues basically. And we were able to, with various advocacy campaigns, so Doctors Without Borders was especially in the MSF Access campaign very active in putting out kind of these advocacy briefs on, medicine shouldn't be a luxury, and insulin 100 years old, especially around the centenary. Insulin was discovered in 1923. So in 2023, there was a lot of this going around. Where the first patient used it in 1923. So there's a lot going on in that regard. And then a big win was at the World Health Assembly in 2021. They, whatchamacallit, signed into effect, or if you will, this high-level resolution on diabetes care, and they included a paragraph on providing concrete guidance to member states for uninterrupted treatment for people with diabetes in humanitarian settings. So they included humanitarian populations in this. So basically now the WHO member states have a mandate to look at this, which is a first step for WHO to be able to take this on. And then they included analog insulins on their essential medicines list, which is was a controversial move, but they went ahead and did that. And then earlier this year, the WHO and the UN Refugee Agency co-hosted this high-level technical meeting in Copenhagen on NCDs in humanitarian settings specifically, which I think from a policy and just galvanizing ministries of health was a big deal. They brought together all of these individuals to discuss this issue and come up with a joint work plan to start to address this. And we hosted a side event on diabetes. This was all NCDs, including oncology and pulmonology and you name it. So we hosted a side event on diabetes, which, yeah, it was a really meaningful event, I will say. And then IATA itself hosts an annual symposium. We had our last one in Athens in May of this year. And we have our next symposium coming up in probably Geneva in June. And we have a roundtable. We have these roundtables once or twice a year, bringing everybody together to give updates and hear, progress, things like that. And we're hiring a communications fundraising consultant, if anyone knows of someone. So that is it. So just to conclude, forced migration is at record high levels and only projected to get worse over the coming years. Protracted crises are the norm. And despite these projections of steep increases in both diabetes and humanitarian crises, the provision of diabetes care is not routinely included in humanitarian responses. And to address this requires sustained collaborative commitment of a diverse network of partners with a shared mission. And just the global trends make this a pressing imperative. So we are a consortium of many organizations, and if any of you are interested or have overlap or any expertise you'd like to share, contribute, we would love your input and your help. So please don't hesitate to reach out. Thank you to our amazing team. This is our group here, and all of my mentors and colleagues over the years. And that's it. I'm happy to take questions.
So thank you so much. This is something I never even thought about. So it's unbelievable. I have a question. I don't know if you have the answer, but do you have any idea how many people have died because of the lack of access to insulin, for example?
No.
No.
Oh
Okay.
God. That has, the numbers for type 1 diabetes are extremely dire. I mean, they just don't show up. They're missed routinely. Especially in very low resource settings. I know a group is trying to quantify this in Gaza now recently, like Johns Hopkins folks based on NCDs, how many people likely will have died not due to no access. I think that work is still ongoing, but we don't know the answer.
Yeah, thank you. Very interesting. On the cold chain, I had a question. I was wondering, is there data on the drop of effectiveness when insulin is out of the fridge as it stays out? I wonder compared to in a refrigerator in particular, maybe it's okay after 1 week.
Yeah, so here.
And then a related question is, this is a similar issue, but of course it's different medicine that the vaccines folks are facing. So I wonder, for that particular issue of storage of medicine, whether you work with, which, in all these conflicts, there's outbreaks of, measles, polio, etc., and cold chain for measles is very important as well.
Yeah, no, that's a great one. I mean, the measles vaccine, I'm not an infectious diseases person, but I understand that the cold chain there is completely critical. Like, it has to be at a certain temperature from the minute it's produced to the minute it's injected, sort of. And we have discussed that with different groups. And the COVID vaccine, you know, you think you could, but it's been difficult. It's been discussed. I think, I don't know why, but so far it hasn't really been shift.
It's vertical. Kind of.
Yeah, they're not really collaborating or not talking amongst each other, and I think the volume question is a bit tricky in procurement. I think there's been some issues around that, but it is something that we're talking about. And I do think like the data on insulin thermostability is actually very reassuring. I mean, when they looked at the insulin out of the fridge at 80 degrees Fahrenheit, like the insulin sitting there for 4 months, virtually all of the different products they tested had more than 95% activity, which is meaningful. You can use it if, you know, if the activity, again, I'm not a biochemist, but like above 95% is considered acceptable. And all but 3 samples met that criteria. And those 3 samples were the older human insulin. All the newer insulins seem to be thermostable at least 2 months out of the fridge, if not 4, quite frankly. So
Doesn't seem an issue.
Huh?
Doesn't seem cold chain is an issue.
So now, of course, pharma needs to answer to this, because this has been probably death sentence for I don't know how many people. Even here, I can't tell, I mean, I practice medicine right here. And a patient of mine, this happens not infrequently, power went out of their fridge. They had like a 3-month supply of insulin. Power goes out for 15 minutes. They throw it all away. I'm like, please don't do that. But anyway, right now, of course, ideally you would store it in the fridge. That is like still preferred. Like I can't say not to do that, but the data is extremely.
The contrary to vaccines, it seems like it's a totally different extreme, which is, I wonder even in the first place, where would you insist on, based on what you said, 2 years or 4 months?
Yeah.
You know, at 30 degrees, 80 Fahrenheit.
Yeah. Yeah, I mean, MSF, because this has been a challenge, they've actually created a insulin storage document for settings where there's no fridge, just to say, this is the data, they summarize all the data. This is what we know. If you otherwise don't have insulin, please use it. Just, and like giving some guidance on how to dose it. Because what I've seen happen in different African countries is they know the insulin may not be as high quality anymore, and so they'll empirically just guesstimate a higher dose, and then they kill people in hypoglycemia. So basically what we're saying is, do not up the dose, use it and just monitor carefully, but don't empirically increase the dose because you think it's ineffective. So anyway, we're putting together some of these things that they wouldn't be official clinical guidelines because you can't recommend that kind of thing officially, right? But just to say, in a very fragile, low resource setting, you know, short of not using it at all, these are some ways in which you could probably use it as safely as possible. But yeah, we're working on that.
Thank you so much. Fascinating work. I wonder how much the global data you cited in the beginning can be used as at least the prior before further data collection can happen. So if something happens right now in province X in country Z, my best guess as how many type 1, type 2 diabetes or overall diabetes cases I can go either to IDF or I'm part of the NCD risk, we produce global trend. That's my best guess, plus minus its own. And then whatever package needs to be sent to be based on that. While we wait on further more specific data collection, because it's not a random sample of the country, but that would be the best.
You mean the United study data we collected, or just the baseline?
Just the baseline for the packages. How many packages do I need? My guess is it's going to be 5%. We have 10,000 people.
I agree completely. I think that would be a very reasonable, logical approach, just to say this is our best estimate, and now all these people are, you know, like for example, leaving Ukraine and now in X country or leaving Sudan and I think that would make a lot of sense. It's just a process is all I can tell you. And the humanitarian part of the issue is this is not yet on most humanitarian providers' radars at all. They're not even they're not even at the stage, I mean, they are increasingly now, for sure. But they're not really at the stage where their disaster preparedness plans have this included much yet. The crisis in Ukraine was an interesting one because they have a very known large burden of NCDs, and the Ministry of Health led most of that response. And they convened the WHO Health Cluster is this cluster that coordinates the response in an acute emergency. And they created a special NCD cluster because they knew the pre-existing data to address diabetes and other NCDs. And they did actually an incredibly phenomenal job given the circumstances. And I was telling Fawn earlier, they set up like a hotline for insulin, the Ministry of Health, so you know where to go. And they would be able to identify individuals. So they did a great job. We're trying to learn from that and have this NCD cluster be more of a consistent thing. Like not every response has an NCD cluster where they're using pre-existing data and then kind of looking for it. If you're not looking for it, you know, it's gone. Yeah. Anyway, but it's a great point, and I think we should be doing that.
Thanks a lot for the lecture. It was really amazing. I didn't even expect that this kind of data already exists. My question is about the prevalence or like the incidence rate of diabetes, especially type 1 among the humanitarian crisis, maybe the latest Sudan and Ukrainian ones. Are you aware of any kind of data that measures this?
In a nutshell, so Gaza, they had data. UNRWA, their electronic medical record, because you know they've been there for so long. Their electronic medical record actually, I'm told, and from every conversation I've had, is probably one of the best ones out there. And they know where the people are with diabetes, including type 1 diabetes, where they are, what insulin they're on. And so when the war now escalated a year ago, they were able to, it wasn't perfect, right? Because it's just completely chaos. But I was on the phone with them a lot of the time, again, switching from one product to the next, but they were able to tell me exactly how many people with type 1 diabetes are in theory there. Again, you don't know mortality rates and that kind of thing quite yet, but like they did a really great job. And so my hope, I was talking to Fong about this earlier, if these kinds of medical records were more readily available, or one of the things we're working on is peer support. So social media and peer support WhatsApp groups, you know, the type 1 community actually is pretty close as opposed to the type 2, you know, type 2 is a whole different thing. But with their WhatsApp channels, they were able to share information very quickly and say, this is where I am. This was also true in the floods in Pakistan a couple of years ago. They were able to locate, they knew where people were with type 1. They were able to figure out where they were based on social media and WhatsApp, and then provide the insulin. So those are two examples. And then Ukraine, of course, is different. They knew they had the data, but Sudan, no way. Ethiopia, part of the political horribleness there was, for a while, the government wasn't letting insulin in the country at all. They just weren't letting it in.
The government.
So that was a big challenge. So anyway, but all of this to say, it's one of the things that we're trying to work on with people with lived experience, you know, having people with diabetes and their networks create social networks so that when something does happen, Brazil is another example where this happened recently with the floods. They were able to locate the kids with type 1 especially, and then provide the insulin through helicopters or drones or boats, or, you know, because so anyway, so there are a few examples, but we need to make it more consistent.
Thank you very much for these insights.
Yeah.
I didn't expect something like this, especially in settings like Gaza or Pakistan, in the middle of like this war and chaos. Thanks for sharing this.
Yeah, of course. Yeah, thank you for coming.
Yes, this is really fascinating. I was just curious if there's any data, especially like low income or like fragile settings, on like the amount of like decay that happens. Or like with MSF hospitals.
So during in our trial, they weren't really measuring that meaningfully. I don't think there's no consistent data and there's no really solid data, again, because everyone's measuring this differently or not at all. And how do you measure DKA? A lot of labs don't have the tests that you would need to be able to diagnose unless you're clinically aware. I don't have to think about it, but I'm not off the top of my head. Is there any really good data? I mean, aside from like US, you know, there was like with hurricanes and New Orleans, there was a lot of data around like natural disasters in high income countries. Japan was another one where there's data, but these very low resource settings, not.
So they diagnose DKA clinically.
Yes, pretty much. I mean, this is how I even got into this, was I was practicing medicine in Uganda in a tiny district hospital near the Congo-Rwanda border. And we had all these young kids and people coming through from Congo. And I remember I was providing general medical care, and we could provide long-term chronic infectious disease care, be that just like treating a pneumonia or TB or HIV. People would get better, molecular testing at the bedside, and people recovered and did quite well, things considered. We had no insulin, hardly, I mean, if we had it, it was like for a day and then not the next day. We may or may not have had strips. None of the kids that are clearly in DKA survived even more than a day. You could smell like there's a fruity odor, right, on the breath. You could just tell these like young, like 14, 15-year-old kids dead. And I just was like, how is this? Diabetes has been around. Insulin is a 100-year-old drug, right? Diabetes has been around forever. It's killing most of the global population now. How is it that this is still the case? It's completely ludicrous. And I think that got the fire going, and here I am. So, but yeah, I think, but on the flip side, and we are increasingly working with the HIV community because it's phenomenal what they've been able to accomplish, right? And I know it's not perfect and there are issues and all of that, but if you want to look at a public health example that was very successful, where they got brand new drugs, low cost or lower cost and like chronic programs into very remote parts of the world, and their advocacy machinery is like fantastic. You know, their advocacy groups are on another level compared to what we have in the NCD community. So we're trying to, and now what's interesting is, especially a large cohort in South Africa, they have a lot of, they have a larger percentage of people living with HIV that are living long lives and now also have diabetes and cardiovascular disease, but they're not getting treatment for their NCDs. And now they're getting like upset because they're like, okay, my viral load is 0, but my blood sugar is like 400, and now they are getting into this. And I think that has real potential because they're activists, a lot of that community, they know how to. So anyway, we're working with them, hopefully, you got to go at it from all angles. So.
My question is more toward preventive care. I wonder, considering the long-term shuffling and people's changes of lifestyles and eating habit, I wonder if you know or if you do any preventive work around.
It's a great question. We should. There's been discussion around it in stable. Well, most crises are protracted and last a very long time. So in those situations, could you do health education and prevention? But in an acute situation, you're just, focused on survival. That's where this nutrition subgroup that we've convened comes in as to like, how might we do that? So the preventative piece and education around that. I think that's a challenge anywhere in the world right now, right? Any resource setting. So the work on that right now is very limited. I think just because it's hard to know how to exactly address that. But there are some programs like MSF, I think, is doing some work in different sites, but it needs a lot of help is the truth of the matter, and something that we should, education in general is really needed. Yeah, that's a great question. Yeah.
Thank you. We have one question on chat. So Abdu, can you unmute yourself and ask your question? If not, I can read in the chat.
Yes, sorry about that. I came in late. I work in type 2 diabetes, and I'm one of those people that's very frustrated by the use of insulin for type 2 diabetes, because we've known for over 20 years now that it increases all-cause mortality while decreasing glycemia. So I was wondering if I missed the big part, if that was something touched on, or is the focus entirely on type 1s? Thank you.
No, the focus is not entirely on type 1. I think because of their the nature of type 1 diabetes, it has been a big focus. But we know most people have type 2. So your question was about the use of insulin in type 2. If you don't mind reframing that, your question.
Yeah, I mean, we have overwhelming evidence now that insulin, type 2 is for the most part hyperinsulinemia. Over a 20-year period before HbA1c indicates that somebody is type 2 diabetic. And we now have quite a few papers showing that if you treat type 2 diabetics with insulin, yes, you can control glycemia for a period of time, but you increase strokes, heart attacks, all-cause mortality, including obesogenic cancers. So it's been frustrating for those of us who work on type 2 that we still keep pushing insulin as an answer for something that, is really too much insulin, too much endogenous insulin, and then we give them exogenous insulin, which causes further damage. Also, we know that hyperinsulinemia, even without type 2, increases heart disease and a whole range of other non-communicable diseases. So I was just worried that the insulin conversation is not looking at the downside of insulin for non-type 1s.
I will say, it's true, hyperinsulinemia, prediabetes, metabolic syndrome increases your cardiovascular risk and outcomes and all of that. Right now, the only options for most of the world to treat type 2 diabetes is metformin, glibenclamide for the most part, and then insulin. Those are the options. I will say, as many of you may know, the newer diabetes drugs that we're using here, the GLP-1s, the SGLT2 inhibitors, the WHO included a year or two ago the SGLT2 inhibitors on their essential medicines list. I don't think they're widely available anywhere in the world right now, but there's a lot of discussion going on within WHO, within our groups, about the GLP-1 agonists, which of course have that stroke risk reduction and weight reduction and benefits on a variety of levels. Not to say we're going to have these drugs in low resource settings tomorrow. We're all very realistic. We're barely keeping up here, but there needs to be a roadmap to make these newer drugs, these non-insulin agents, available. Like, what's the plan in 5 or 10 years from now that these drugs will be accessible in lower resource settings, because they are the way forward, right? We now treat with these drugs predominantly. So those are conversations we're having with pharmaceutical companies, with different, it's an early discussion, but there's a lot of interest in this. And I'm not a medicines access specialist, so it's a nuanced discussion, but we're planning different meetings to just at least think about, because unless you think about it now, it's not. So that's where we are with that. A lot of work to do.
Before we reach the top of the hour, I just want to thank you so much for all of the work that you've done. I watched you over the last decade, just bringing this from an idea into now huge alliances with a lot of programs, impactful programs. So thank you for all you do for our communities. And thank you all for attending today's sessions. It's a pleasure having you here.
Thank you for coming.